Good afternoon and welcome to Sustainable Population Health, One Health Systems Journey, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat. Actually, today it's hosted by Nancy Wilcox, our Director of Marketing and Sales. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. Other WebEx panels we'll be using today will be the Q&A panel. You can use that to submit questions as they occur to you. Send them in and leave the default set to all panelists, and we'll take them later in the program. And you can download the deck by using the URL on your screen, and it's at the bottom of some of our slides. It will also be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to hear from our featured speaker, Terri Steinberg, Chief Health Information Officer and VP of Population Health Informatics with Christiana Care Health System. So without further delay, we're going to turn it over to Terri Steinberg. Terri, thanks so much for joining us today.
Thank you, Anthony, and good afternoon. Thank you for this opportunity for letting me speak to your audience. I want to start just with a couple of words about Christiana Care Health System. Essentially, we are a large hospital system in a small state with about 1,000 beds, 11,000 or so employees, and we are a major teaching affiliate of Thomas Jefferson University. There are three important components about Christiana Care that I'd like to share with you that will provide a framework for my comments for the rest of this hour. I'd like to introduce you to the notion of CareLink Care Now. This is a wholly owned subsidiary of Christiana Care Health System, and it is a care management company that uses an IT-enabled care management system and programming to provide care management for Medicare beneficiaries, health plan members, and Christiana Care patients all across Delaware. We also participate in eBright Health, which is a multi-hospital system consortium across the state of Delaware, and an important customer of CareLink Care Now care management company is eBright Health ACO, which is a Medicare shared savings program with about 50,000 Medicare beneficiaries. So I'm going to skip a couple of slides because I want to make sure that we have time for questions at the end. And I'm going to move right on into our population health programming. And I'm going to refer historically how we got here today, but I really want to spend most of my time talking about how we deliver population health programming and how it's focused on care management. So the U.S. Capitol building is here to remind us that there's a lot of national conversation about payment reform, about health plans. One way or another, I think it's probably not all that relevant how these individual questions are going to be resolved, because the fact of the matter is that healthcare processes will follow the money, and pay for value is here to stay. I think that we all can agree that fee-for-service medicine is on its way out, and both quality and outcomes are important parameters of how care will be delivered in the future. At Christiana Care, we began our journey in 2012, and we endeavored to implement two innovations that became the keystone of our population health programming. Although in 2012, nobody was really talking much about population health. We believed that it was important to provide provider-based comprehensive care management instead of the payer-based care management that we've all experienced, and that an analytics-based technology platform should be used to identify who needed more care and who needed less care so that care could be customized. Over the years, this evolved from a small pilot program that was funded mainly by a grant, but also with Christiana Care's funds, into a care management company that Christiana Care owns with a full risk goal. So essentially, in the future, Christiana Care endeavors to move towards a full risk model, almost completely abandoning fee-for-service. And the most important reason for this is I think we all recognize that there are some very important components of healthcare delivery that you can't drop a bill for. Social work services, and does the patient have transportation for follow-up, and can the patient, put food on the table and pay for the medications? None of this can be covered with traditional fee-for-service medicine, and if there's one lesson that we learned with this early 2012 platform of care management programming was that things that we didn't think and we didn't realize were important proved to be extremely important and game-changing in healthcare delivery. So this evolved to what we call CareLink Care Now. That's our logo at the bottom right, which is a wholly owned subsidiary of Christiana Care. It's a care management company that provides contracts to ACOs, direct-to-employer contracts, and partnership with payers. We have about 102,000 lives, soon to grow to about 180 when we implement our next phase. And what's important to realize about CareLink Care Now is that the majority of people that are care managed through this entity are not Christiana Care patients. So when CareLink Care Now reaches out to members, we do so on behalf of the doctor's office. So this is Terri Steinberg, care manager, calling from Dr. So-and-so's office, but these are not Christiana Care patients necessarily. So it's a very new paradigm where the care managers partner with all kinds of providers in order to provide the glue between visits and encounters for the members that it covers. So some of the strategies that we've used include exposing performance in real time to providers. So, when we set goals for quality and for outcomes, it's important to inform the people who are executing those goals how they're doing. We use analytics to identify high and low risk members. I'm not going to spend a lot of time on the IT analytics platform, but suffice it to say that we use prediction analytics to segment the population into high risk and low risk, and we're able to customize the care that's delivered to an individual member. For example, an emergency department visit for someone who is low risk is going to look, the follow-up to that rather, is going to look very different if the person is high risk. And so customized care is really an important component of our population health strategy. It's really important to understand the population's overall characteristics, and so we endeavor at CareLink to receive data feeds from any and all possible sources: clinical, financial, social, economic, etc. CareLink implements standardized evidence-based care, and there's a really important mantra that CareLink promotes, that the practices that CareLink supports promotes, and that is measure what you do and don't do things you can't measure. If it's important to do, we feel that you need to provide outcomes and some visibility to whether it's being effective. And so with respect to outcomes, we look at both improved utilization, readmissions, and more important, admissions, as well as cost savings. But we've noticed that cost savings, very interestingly, are less pronounced than utilization. So we move the needle quite a bit for utilization, less so for cost. And I consider this to be a really early science, so we don't know exactly why that is, but we have that and a host of other questions will be answered over the next few years. Most important, we have noticed really improved provider and patient satisfaction, and later in the hour I'm going to give you some very specific outcomes that we've realized. I'm going to, as I said, I'm going to skip some slides so that we get through the hour. To describe specifically our population health strategy, I've stolen shamelessly from the state of Connecticut, who legislated a framework to limit healthcare cost growth, which I found in itself remarkable that a state has legislated such a framework. I added a couple of puzzle pieces to this, but essentially this is their paradigm. And I'm going to walk through what each of these components refers to. So, first and foremost, the goal to improve population health. But let's start with a question. What is population health? I'm sure, if I asked everyone to input what their idea of population health is, I would get 10 or 20 different answers. So for the purposes of this conversation today, population health is going to refer to the management of costs and outcomes for any defined group, patients, insurance plan members, those who have chronic disease or conditions, but it will not be a population of NICU babies and their outcome. This is definitely cost and outcome, and however you might slice that. In order to think of population health in this way, it really does require that we think about people differently. So not every person who's of interest in population health is a patient. I referred to that earlier when I mentioned that many of the people that CareLink Care Now manages are not Christiana Care patients. They're someone else's patients, somewhere else geographically across the state of Delaware or in Maryland or in some of the surrounding states. And then finally, in order to practice effective population health, it's essential to segment the population for success so that you can deliver the right-sized care with customized intervention, but even more important, so that you can find the people who need care before they self-identify. So there are three components for effective population management, and I've actually referred to them already. The first is technology, and that is to take all the information, all the data you can find about a person, clinical, financial, socioeconomic, et cetera, and put it all in a single place on which you can run analytics. And that is a risk assessment, some way that you can figure out who is going to have a negative outcome, be it quality, cost, so that you can intervene and prevent that from happening. And then finally, do this all through care coordination that becomes the glue between visits or encounters. The old mantra was that hospitalizations are expensive episodes, so try and avoid those. Well, it turns out that doctors' offices aren't inexpensive, and so the idea is, especially for millennials who want their health care on their phones, provide the glue that moves people to the right-sized care at the right time when they need it. And you can do that using these three components, and those are the components that we've implemented in CareLink Care Now. So this is our population, and the general idea is to find those blue people who might have diabetes or hypertension or might need a mammogram. And when you think about it, the horizon for developing an expensive and troublesome complication is relatively short. Let's pretend that one of those blue people had uncontrolled hypertension, and that's a silent disease. Very often people have uncontrolled hypertension without realizing it. Well, only about 5 years or so of that needs to occur before you develop end-stage renal disease. Doesn't always happen, but it can happen. And so the notion of knowing who hasn't had their blood pressure checked in 5 years is important. It used to be, if you don't have a claim, that's good news. We don't have to spend money on you, and that's a success. That's not how we think of it anymore. So we have to constantly manage all 102,000 members, whether it be for a chronic disease or because the person hasn't come in for their annual visit or they haven't had their mammogram. And so that's a very different care management paradigm from the care management that's delivered by the payers after an event has occurred or when a prior authorization has been delivered. And that's when we usually hear from the care managers. Most people don't pay a lot of attention to that sort of care management because they're not aware of the individual history or scenario. So when you think about how to find the blue people, which is essentially the methods to segment a population, you think about prediction analytics in order to risk stratify who needs what, and there are many, 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 many different needs and many different tasks. I will say at Christiana Care in 2012, the systems didn't exist to do this, so we ended up building the majority of these at home. It was painful. We are in the process of now migrating these homegrown systems to commercially available systems, which is very nice. And then you have to make sure that once you learn who needs care, you deliver it properly to the right the right person or the right delivery method. So for example, when we first started in 2012, the output of our prediction engine was a giant spreadsheet with people's risk scores, and we said to the care managers, here you go, start calling people. Well, that wasn't effective. So today, we generate a work list task for those who have a rising risk score or a clinical result that needs intervention or an overdue mammogram, and the care managers simply work their lists. So when you think about it, they're actually managing everyone, and it's the data system that is bringing those who need attention to their work list, and it's actually highly effective. In many cases, some of those outreaches are automated. For example, you might send a text message to a member asking how a person is doing. If you're managing somebody for heart failure, the system can generate a text message once a week that says, you know, press 1 if you're having difficulty laying down flat, or you might generate a phone call with voice responses, or you might generate a letter, or you might have a human being make a phone call. So the idea is that you have to right-size your intervention to your particular population. And that's going to look very, very different for our Medicare beneficiaries than it is for our employees. And we've learned that we need to be highly flexible. So we're actually trying many different sorts of interventions as pilots, and some of them work well, some of them don't work so well. So the second pillar of population health strategy is to cap the growth of costs. Notice I don't say reduce costs, because that's really an unrealistic goal. But this is all about value, increased quality. The denominator of the equation is cost, so quality over cost equals value. You can increase one, reduce another, and end up where you need to be. And so that requires that you measure quality and cost, and that you feed these back to the providers. As I said, if you don't measure, you don't do it. If you don't measure it, you shouldn't be doing it. And but it's important to recognize that healthcare is expensive, and especially some of the new pharmaceutical technologies are very expensive. And we don't exactly know how to accommodate $1 million, you know, genetic manipulation. We don't know if that's how that should be applied to populations, and so we're still learning. But we have to be mindful that healthcare in general is expensive. And then finally, the other thing to be aware of as we think about capping costs is the economic impact that this has on communities. In the area surrounding a large healthcare organization, people work for that healthcare organization, and it's a strong economic driver that needs to be handled carefully. So just some food for thought. I don't pretend to have any answers about this at all. A third pillar is the support for providers as they transform to the new payment models and new delivery paradigms. And that's, first and foremost, is to help them embrace new care delivery methods. This is really hard because the primary care docs are the primary players in this, and they are so busy and so overworked that they don't have enough time to efficiently reorganize their practice, much less understand how they're even doing in terms of quality and cost. So what we do at CareLink is we partner with the practices and we provide them the data they need, which is actually very different from the reports that come from payers, which are 3 months late and very often inaccurate. I'm going to show you some of the dashboards later that we show them, the idea being that we spoon feed them how they're doing and we help them reorganize so that they can have everybody working to the top of their license so that they can reallocate roles and responsibilities and become overall more efficient. We also, at CareLink, help them by taking over inter-visit management. Very often, some of the follow-ups that they do, because there's no one else besides the primary care provider to do it, can be done through effective care management, whether it be social worker, pharmacy, care manager, et cetera. And we do this with telehealth visits or video visits or even chats directly with the care manager. Whatever communication method and delivery method works, we will use. And then finally, we work with the practices to help patients assume personal responsibility for their outcomes. A little more about this later. So, we need to understand that the market is changing. And if you told me 10 years ago that CareLink would be working hand in hand with the payers, or that health systems who were across the street from one another would be working together, I wouldn't have believed it, but it's true. So the notion of collaborative competition is here to stay. Provider and payer relationships, you know, I spend half my day talking to payers. This is the new reality because it's a common goal: improve quality, reduce costs. And then finally, as I said earlier, the establishment of risk-based payment models is absolutely necessary to ensure that essential services for which no reimbursement under fee-for-service is available will be provided. And I listed some here: social services, food programs, literacy, employment. These are all components of healthcare, but a few years ago, nobody would have thought that was the case. Data analytics. So today I spend the majority of my time thinking about questions to ask our robust data structures. And it's really important when you think of how you're going to segment your population, you really start by thinking of your resources. So if you've got sufficient resources to address your top 10% highest risk, you do that. If you've only got resources for 2%, you do that. The important thing is to recognize who your riskiest people are, whether they are patients or members, and apply something to those patients to move the needle. And it's all about resources and recognizing how you segment your population. Everyone should be enrolled in a wellness program, and so population health is really more than just disease management, it's wellness management. Then most important, maybe not most important, but almost most important, is the people who are not being seen, who are lost to care, not likely to see providers, those people who have asthma but who keep refilling their meds and not seeing a provider for 5 years, those are the very ones that you need to find to prevent the diseases that are silently brewing. If you can catch one pregnancy early and prevent one neonatal ICU admission, you've saved $1 million and you've done a good deed for the baby and the family. So most important is that the riskiest enrollee, and this is what I said in red, the most expensive one is the very person who you're not dropping a bill for and is not likely to seek medical attention. And so when you look at analytics in general, you know, this is, I've stolen from Gartner, this is their analytic value escalator. Most everyone to some degree does, you know, descriptive analytics, what happened. At CareLink, we've moved on to prediction analytics, what will happen, so that we know how to move the needle, how to drive the outcome to some degree. But we can't make it happen all the time. In fact, we can rarely make it happen, and part of the reason is that we don't yet know how to make it happen. Specifically, we don't know how to do provider-based care management effectively. We think we do, you know, we're trying some things. But for example, is a phone call 24 hours after discharge from a hospital important? Should it be 12 hours? Should it be eliminated because it's not important? Is a follow-up after discharge within 7 days important? Could it be 14 days? Should it be 3 days? So I think that very often our evidence-based practices are highly established within the walls of a hospital or an office, but we don't know how to manage transitions of care, and we actually don't know how to do provider-based care management. So I've recently added to our database of clinical data and claims data our care management interventions data. So I've dumped that system's data into the same data mart, and we're going to start to look at what are the most effective interventions in terms of value and how to support this and how to change our practice. So it's really, I think over the next few years we will learn how to do care management, but I don't presume that we know how to do it today from a provider perspective. So, use dashboards. I think that's really important. You need to provide the data in the way that is easy for the recipient to digest, and it's not always the same. So providers like dashboards, people who worry about the finances of the ACO need a, PM analyzer framework, and it's just not the same. So we need to customize our data for the recipient, and we need to understand that changing practice in response to data is a team sport. So, it's the person who does the scheduling and the doctor and the nurse and everybody else involved, in addition to the care manager, who need to review these data dashboards and decide how they're going to change how they operate. So here's an example of one of the dashboards. It's a real-life early incarnation of one of our care management dashboards that we provide to the practices. On a regular basis, the practice closes down for an hour and they sit with the care managers for that practice, and they look at their outcomes. They look at their utilization rate. They look at their utilization by encounter type, whether it's short stay or length of stay. They look at their readmissions. They look at this map down there, shows where their catchment area is, et cetera. And we have many such dashboards. These are they're very well accepted by the practices, and increasingly the practices are starting to receive these on a self-serve basis, where they'll log in and they'll pull down their own data and review it on their own, which is the direction we'd like to see them going in. Another important premise is the notion of aligning and coordinating strategies. You don't want your physicians to be rewarded on the basis of volume if you're rewarding the organization or the practice, say a hospital-owned practice, on the basis of performance. So either everybody needs to be volume rewarded or everybody needs to be quality rewarded, but you can't mix the two. And I think increasingly this underscores the importance of ambulatory care. And then finally, provider and payer collaboration is very difficult because these two used to be enemies, but they need to start to work together. Then finally, what I call the last 100 feet problem is that members need to be engaged, and that will be the game changer. When the members themselves start seeking out this care management, this optimal outcomes, when they are aware of when they need preventive services and they go after their mammograms or their colonoscopies, or they come in to have their blood pressure checked or their annual visit. And that's really the development of personal responsibility. And there are a number of initiatives that might work. Some of the employee health plan programs have started to disincentivize bad social behavior like smoking, or I should say personal behavior. Smoking weight loss is incentivized. You either direct co-payment reduction or other methods, but so the employers have started to do some of this. The important thing is that you need to make the goals visible to the members using whatever tools they will find helpful, whether it's a smartphone portal or an app. At Carolyn Care Now, we're trying many different pilot technologies, including diabetes management programs, biometric device integration with dashboards so that people can see what their blood pressure is, they can monitor their weight. There's gamification of weight loss with incentives. There are all kinds of things that can be used. Again, we don't really know what works, but it's most important to engage the members, the patients, in this conversation. And then finally, I think sometimes old methods work, like asking people to keep track of their blood sugars or their blood pressure measurements. But over time, as the younger generation becomes the middle-aged generation, I think that we will be doing this all electronically. So we are very much invested at CareLink Care Now to find what works in terms of the multiple technologies that are out there. Anybody who walks the HIMSS floors knows how many technologies there are there, and we're committed to trying as many as we can. So just a few words before I break for questions about some outcomes and results. So this population is total knee or hip replacement, and this looks at the percentage of people who have been able to go home to their own homes instead of to skilled nursing facilities or some other assisted living. And we've noticed a 30% increase since we've started care managing this population in those who can go home. So obviously that's a big win financially as well as in patient satisfaction. Nobody wants to go to a nursing home. We've also noticed a decrease in readmissions for those people who are able to go home. So it's a 30% decrease in readmissions after that procedure if you go home, which is also a great thing. For people who are being managed in congestive heart failure care management programs, we've increased 12% those who can go home instead of to nursing homes. And the way we do this, at Christiana Care in particular, it's a single care management team. Everybody wears the same uniform, so if you're in your bed with heart failure, you're going to be introduced to a care manager using the same system that will be used to follow you when you go home. If it's one of the other hospitals in which we manage patients, these would be the other hospital's patients, CareLink's members. We're going to communicate telephonically. We're going to interface with that hospital's care managers, but they will know who CareLink is before they go home, and that follow-up will occur immediately. So 12% improvement in those data. We've also noticed a 14% reduction in readmission for the congestive heart failure patients who can go home. And then finally, if you do go to a nursing home, there is a reduction in return rates and readmission for those people who go to skilled nursing facilities. I think this is going to be my last slide so that we can break for questions. But I just want to say a few words about whether it was or was not difficult for the practices to adopt this sort of care management model. After all, Dr. So-and-so doesn't really know CareLink Care Now, doesn't know Susie Care Manager, doesn't really know much about Christiana Care, and in fact, that doctor may be 100 miles away or may be a member of a health system that views Christiana Care as a competitor. So why wasn't it as difficult as one would think? Well, first of all, doctors are data-driven. And the proof is in the results. So they see their patients are happier, they see that their schedules are lighter, and they see that they have help where they didn't have it before. Clinicians are competitive. Those dashboards that I showed you, you can click right down to the provider level. So you can see that practice A has more readmissions than practice B. You can see that Dr. A in a practice has more readmissions than Dr. B, and that is those are very compelling data. In almost all cases, the financial incentives to reduce utilization are aligned. If they're not, I don't think the adoption is going to be so great. And then, most importantly, providers are really grateful for the help. So one of my colleagues points out that if you give an internist or a family doctor, a social worker, you'll bring that provider to tears because social workers are so valued, but they're a resource that didn't exist before. So we've added to their existing team in a way that really allows the primary care providers to stretch their resources. We've done it without additional cost to the providers. Why? Because it's a risk-based contract. And if the outcomes are are better and the cost is lower, everybody wins, including CareLink. So that's why we do it, and that's how we do it. And then finally, it's good citizenship. So even the skilled nursing facilities who have noticed, definitely noticed, a reduction in utilization from as a result of this activity. Remember, Delaware is a small state, and we all know one another. They believe that it's the right thing to do. So they want their beds filled with people who need to be there, and we want people who can go home to go home, and the patients want that too. So again, aligned incentives result in excellent adoption. So with that, I think I'm going to stop here, even though there are a few more slides that you can take a look at. And I guess we will entertain some questions.
All right, very good, Terri. Thank you so much for that presentation. Lots of information in there for people to take away. Let's have our Q&A now, so just remind the audience to go ahead and type your questions into the Q&A box. Leave the defaults up for all panelists, and we'll get them to Terri. First question that's come in. Your solution seems very robust, yet you mentioned you're always on the lookout. What exactly are you looking for, given that you have something so powerful in production already?
Oh, that's such a good question. There are actually three components to my technology platform. One is, I call it the red sand bucket. That's where we put all the data. It's an operational data store, and that's where we also run business logic. So it's this very important, giant homegrown system. I don't want to be in the software development business. That's not a core competence. It shouldn't be. We should move that to commercial software. So I'm always looking for commercial software to replace our system. The other two components are the care management platform. So we use a commercial care management platform. And we deliver, but we customize it by delivering messages generated by the business logic. Think of our operational data store as middleware that generates messages that then, using web services, end up in front of the care managers. And then finally, the third component is our prediction risk score. In 2012, prediction risk for healthcare was, nobody was doing it. We started to do it. There was one company that, nationally that we thought could do it. We kind of developed this collaboratively. Now predictive engines are commodities. It doesn't matter whether you use ours, IBM Watson, it doesn't make any difference. Health Catalyst, they all work. And so, my platform is very expensive. It's been developed for a customer of one, and I'm looking to dramatically reduce the costs of the IT operations because we have to pass these along to our care management contracts. So in addition, a lot of the consumer tools are brand new. Think about HIPAA secure text messaging, video conferencing, biometric device integration with dashboards on the smartphone for patients. I'm always looking for the cool stuff that's coming along, and we'll try it. We'll try it as a pilot. If it works, we'll keep it. If it doesn't work, we'll move on to something else.
Very good. Someone in your position, Terri, the lifeblood of what you're doing is data, right? So talk to me a little bit about your relationship with the folks at your health system that are involved in data governance and making sure the data that you're living off of is high quality.
Oh, another really good question. So interestingly, I have the secret which I'm about to share is that I don't really like data all that much. I like implementing the systems that generate data, and I like the answers to the questions that data provide. So the way we are organized at Christiana Care is that there is a central data group at Christiana Care, and I am their customer. So my systems generate data. It goes right into their structures, and they then own it in terms of governance, asking and answering questions. We, of course, work collaboratively, but my group primarily runs the systems for population health and then generate data to this, to our central enterprise information management group. Now, because I'm both the Chief Health Information Officer and the Vice President for Population Health Informatics, which is really, you know, a two-headed beast, I end up having a foot in both areas. But suffice it to say, we were unwilling to compromise on data governance and strategy and really just good data practices, so we organized in that way.
Very good. Talk a little bit more about that last mile, about the process, the best processes you've come up with to actually get folks to change behavior.
Okay, well, you know, I think that let's use the example of somebody who needs to lose weight. And, you know, they go for their annual physical and their doctor either brings up the weight issue tangentially or doesn't say a word. And, you know, in what I've seen with what one of my friends has once told me is that her doctor made a big issue about her weight, and so she didn't want to go back anymore to that doctor. Or the doctor says nothing, so that's a problem, or the doctor says nothing, which is also a problem. This is where medicine as a team sport really comes into play. The care managers, using whatever tools they can use that appeal to the particular individual, can get involved. If the issue is hypertension in one of our Medicare beneficiaries, that might look like a care manager is talking on the phone to that person. If it's a weight control program for a young person, it might be a text message, or it might be a video platform visit for some with a dietitian, or it may be even group support for weight loss. However, we have all of this programming, and I think the important thing is that the doctor's office does not have time or even the skills or the tools to interface on an intensive, ongoing basis with the patients. So the last 100 feet is somebody, specifically the care management organization, whether it be a social worker or a nutritionist or a pharmacist or a care manager nurse, working with that person using whatever tool is best suited to that person. And that's a new paradigm. So, you know, care management that's used as an outreach for the provider is not something that's been around for a long time, but it's highly effective because very often the very thing that you're trying to manage is a multidisciplinary issue. So back to the weight loss example, you need a nutritionist and a social worker and a clinician involved, and sometimes all of the above at the same time, and care management can deliver that. So the tools are going to be different. You know, we're pretty excited about HIPAA secure text messaging. We think that that's going to be a great way for the younger population, the employed population, to really get some of the things they need. But the telephone works too, and is especially useful for our Medicare beneficiaries.
Very good. You had mentioned working with payers can be difficult, old enemies having to work together closely and become better friends. And in a sense, health systems are going to become payers. Is that a way to describe it, that health systems, as they go more and more at risk, they're becoming the payer in this scenario? Is that correct?
To some degree. I mean, I think it depends. The fact is that many employers, many large employers, are now self-insured, so that the payers become administrators essentially of the contract, so that the risk really is attributed to the employer. So to some degree, some health systems will want to formally become a payer, and there are health systems, as you know, that have established you know, insurance arms, and they will cover, you know, any number of entities in addition to their own employees. But many health organizations really don't want to do that. Christiana Care doesn't want to do that. We don't want to we don't want to cut checks. We don't want to have a national provider network. You know, I think there will continue to be a role for payers. There will continue to be a role for providers, and those people who self-insure will end up assuming most of the risk. So I think it's going to change. But one thing is for sure, providers and payers are not enemies anymore, and the interests are aligned and must be aligned for this value-based care delivery paradigm to work.
Very true, very true. We talked about all the data and the data governance and things like that, and you mentioned that the tools are out there, and they're not interchangeable, but there are many tools that work out there. Can you give any of our audience help in looking for the right tool for them without mentioning specific vendors, just a process by which finding what works for you? Does it depend on your structure or what you're up to? Any advice on finding the right tools?
So yes, I think that there's sort of a hierarchy of programming. So, you know, people ask me all the time, you have 3 components to your IT platform, you know, where did you start? And the answer is, we drove down the road at 60 miles an hour while we were changing our clothes. We did it all at the same time. First thing you need to do is you need to provide your care managers with an application. I mean, it doesn't matter what the application is, but you need to know what your requirements are. So if I were going to do this over, I would first stand up a care management application, and that application will vary based on who you are. So as you've learned, we are not necessarily affiliated with any one hospital or provider group. Therefore, it doesn't matter whether we are on the same EMR or care management application is the same as our hospital or ambulatory EMR. Why? Because we have all the providers in the state of Delaware, and they all have different EMRs, and we have 6 hospitals who have different EMRs. So that's, for us, being on the same platform doesn't matter. If you're doing care management solely for your organization, well, then it might matter. So pick your care management application first and make sure that you nail down your requirements very carefully, and that you choose accordingly based on those requirements. The next is your risk prediction engine. That's definitely dessert. You can't use it if you don't have a care management application, so do it later. In this case, I consider risk prediction engines to be a commodity. They all work. There are lots of people who do it. The magic is your data modeler, so make sure that either the company has data modelers or that you've got them in-house, and that you're able to be very flexible and nimble looking at your data models and your prediction algorithms, so that you can change them as needed by population, by age, however you need to change it. And then just find one that fits your pocketbook that makes sense to you. And then finally, the ability to concentrate the data into one place. Pick one of those 2 systems. Ours is a separate system, and I like it to be one of those 2 systems. So I have 3. Most everyone else should have 2 if they were to start today.
Excellent, excellent stuff, Terri. Thank you so much. Well, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. Please take a moment to answer that. Regarding continuing education, attending our events gets you 1 CEU towards the CHIME CHCIO certification program, so let CHIME know you were here. And if you've asked us to do so, we will. You'll receive an email when our archive recording has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox, and you can go to our website to view our upcoming schedule. So with that, I want to again thank our speaker, Dr. Terri Steinberg, and I want to thank you, our attendees, for coming to our events. Everybody have a wonderful day. Thank you.